This is the radiograph of the patient whose arteriogram you've just seen. If we look on this side on a diagram, we see the aortic arch that we've just been going through, and we see the gap below the aortic arch and above the left pulmonary artery. Now, if you look in that region very closely, you'll see a white band here. That band, of course, is ligamentum arteriosum. That's a very important anatomic landmark embryologically and an important landmark to the surgeon, perhaps, but unfortunately it's never seen radiologically. Sometimes there'll be a calcified lymph node in that region, as we'll see in a moment, but this structure itself is not visualized radiologically. We just have to know where it is, approximately in the middle of the aorta down to where the left pulmonary artery leaves the main pulmonary artery. This little gap represents the AP window. If we move down right into the AP window in this patient, you'll notice all sorts of irregular densities in here. Now, I'm sure that one of those is, in fact, the ligamentum arteriosum, but I really have no idea which. The other densities presumably represent small lymph nodes in this region. We now, of course, have a descending aorta and an ascending aorta that are separated. On the right side of the mediastinum, we have the superior vena cava, and curving around from its posterior wall to the front of the spine, we have the azygous vein, which we'll look at a little bit more in a while. Calcified lymph nodes in the AP window are seen fairly often, and it's very useful to look at them to appreciate how big a lymph node you may have in that region without it becoming border forming and becoming conspicuous on the plain chest film. Here is the frontal view showing a typical location for calcification of a ligamentum arteriosum node, or a so-called node of the AP window, and here you see the lateral view of that patient to show you the node. Here's the bottom of the node over here, and it's slightly anterior within the AP window in a typical location right adjacent to where the ligamentum arteriosum would be if we could see it. An interesting finding that you'll sometimes see on CT scans as you look in the AP window is this air bubble. Now, what's that doing in there? What do we have available for air bubbles? We have the esophagus. On the other hand, it looks like the esophagus is still back here behind the trachea. If you do serial cuts on that patient, you'll see that the esophagus is stretched out around the trachea and underneath the aortic arch. You will see this in some patients with a tortuous aorta. For example, this patient, not the one with the CT scan, but a very similar one, you can see an air bubble in the esophagus just below the aortic arch being pulled way over here. This is the left wall of the esophagus. The right wall of the esophagus is here. Don't confuse that air shadow with the shadow of the left bronchus. Perhaps this would be more clear if I put some contrast material in the esophagus, and you can see that it is held over there. Notice that there's an air bubble in the esophagus even when the patient is swallowing barium. If you then make a cut through the mediastinum like so to the AP window, you're going to see esophagus right underneath the center of the aortic arch. If we go down a little further, looking through the AP window, we will see another mass density appear. Now, it may vary a great deal in appearance. In this case, I've portrayed it just as a simple oval shadow to alert you to the fact that it can look just like a lymph node mass. But in fact, what we are reaching is the top of the left pulmonary artery. Notice that the rest of the anatomy at this level is pretty simple. The superior vena cava with the azygous vein coming back, esophagus, and trachea. Let's look at a scan at a fairly similar level. Here we see that this is obviously a vessel because it runs right out into an intrapulmonary vessel. Sometimes you have to compare the lung window pictures with the mediastinal window pictures in order to appreciate that relationship. The partial volume effect, of course, runs us into the main pulmonary artery a little bit as well. But notice that the first thing you reach when you come down from the aortic arch is the top of the left pulmonary artery. It is the highest part of the pulmonary circulation. Let's look behind the trachea for just a second. The esophagus pulled over to the left, as we might expect with this tortuous aorta. But there's another shadow now behind the trachea. Well, notice over here behind the superior vena cava is a little bit of the azygos vein. This is a portion, the lower portion of the arch. Remember, it goes higher as it goes across the middle next to the trachea. And this is the first part of the azygos vein as we see it next to the spine. Now, the thing to be aware of is that the azygos vein often looks larger here than it does further down in front of the spine. And once again, you should remember there will always be an azygos vein, and therefore you must account for the azygos vein before you assign this enlarged density to something like an abnormal lymph node. If we look at this mediastinum, we have the descending aorta, the ascending aorta. We have a little bit of the azygos vein over here, in fact, as we discussed before. Another rather peculiar density here, but remember, you have to have an esophagus, so we can say that's the esophagus. We have the beginning of the main pulmonary artery here, and we should be going into the left pulmonary artery, but this shadow is much too round and separated from the main pulmonary artery in a very non-anatomic fashion. This must be something extra. Let's look at the adjacent cut. Well, yes, it's something in the fat pad next to the aortic arch. It's not the pulmonary artery, certainly. What is it? Well, it's a metastatic lymph node in that fat pad next to the aorta and in the AP window. For your interest, here's the chest film on this patient. You can see the aortic arch here. You can see the left pulmonary artery coming up, but you can't see the top of the left pulmonary artery because there is this mass shadow encroaching on it and obliterating it, and this is the mass that we were seeing in our transverse scan through the AP window and along the aortic arch in this region. Let's look at something else that you may see in the region of the AP window. Here is a convexity sticking out above the level of the left pulmonary artery, which is down at this level in this patient with an arteriosclerotic aorta. What is it? Well, is it a lymph node? No, it's not. Here's a CT scan right through the AP window. Notice this little accumulation of small densities between the ascending aorta and the descending aorta. And we see that there is a round shadow sticking out of the side of the aorta with a defect in the wall here. This represents a small aneurysm. Let me show you the adjacent cut. Below that, there's the aneurysm displacing the pleura. Here's the ascending aorta. Notice that on this cut, you cannot actually appreciate the origin of this aneurysm from the ascending aorta because it is bulging upwards from its actual origin, which we've just seen. What's this shadow? This other mass shadow within the AP window? That's the top of the left pulmonary artery. That's the normal structure to see in that region. Since we started getting interested in looking at the AP window very critically on plain films of the chest, once you begin to appreciate that there should be some concavity between the pulmonary artery and the aorta, you notice little bumps and irregularities there. I've shown you a small aneurysm of the ascending aorta presenting there. Obviously, an aneurysm of the descending aorta could also present in that window. But there are some other variants that may present there that are not significantly pathologic, and here's a very interesting example. This patient has a small bump above the level of the left pulmonary artery, which is right here, below the level of the aortic arch. Now, that's not a very big bump, but it's certainly not a normal shadow. What is it? Well, we did a couple of things on this patient, one of which was to do a CT scan. Here we start off, as you see, at the level of the aortic arch, which we're now familiar with as our starting point. Nice demonstration of a portion of the azygos vein. And here, someone who has a very patulous air-filled esophagus. In the fat pad, lateral to the aorta, we just see a vascular structure in cross-section. We don't see anything else yet. Let's go down one cut. Here we are beginning to clip the top of the pulmonary artery, the left pulmonary artery here. This patient does not have much of an AP window, but we don't see a discrete mass. We see, however, border forming is a continuation of that vascular structure we saw before. If you go down further, this is lost in the shadow of the pulmonary artery, just as it was on the chest film. Well, that must be a vascular structure. How did we prove that was a vascular structure? We went and took the patient back to fluoroscopy, put him back in the upright position where we had seen it on the routine chest film, and then had him breathe deeply in and out. This structure changed size, confirming the correlation between the CT scan and the chest film. This was, in fact, a vein. Now, what vessel should be running in that region? Well, let's look at the anatomy diagram again. If we look at the left side of the mediastinum, there is a vein which drapes across the aortic arch. Now, the artist has drawn it here right at the top of the aortic arch. In fact, it may cross way up here and be very inconspicuous. It may cross along the convexity of the aortic arch, as I'll show you in a moment, or, as in the present case, it apparently droops down far enough to reach the AP window and helps to fill in what should be a concave region here. What vein is this? This is a tributary of the left brachiocephalic vein here, where it is called the superior intercostal vein on the left. But back here, it's a continuation of the hemiazygous system, and therefore it's also called the accessory hemiazygous, and that is one in the same vein that's coming across here, and it's also known somewhat irreverently as the aortic tit because of its appearance on the chest film when it is over the aortic arch and when it is engorged, as it is in this patient with heart failure. So that is the vein which in our other patient sagged into the AP window and looked like a discrete mass. We now recognize that to be a normal variant. A couple more pictures of the anatomy of this vein. Here, a venogram, a patient with obstruction, partial obstruction at this level, shows very nicely how this vein is a tributary of the left brachiocephalic vein, how it curves around the aortic arch and joins the hemiazygous system, which you will recall runs across the mediastinum to join the azygous vein, which you can see end on over here. As I mentioned before with left superior vena cavas, sometimes catheters may reveal some of these anatomic structures for us. If you look very closely here, you'll see that this catheter, which was put in from the left subclavian, followed the brachiocephalic vein, but instead of crossing the mediastinum, as it should, it curves around and out around the aortic arch and then down again into the hemiazygous system. This vein has entered the superior intercostal vein and then gone on around the aortic arch. That's a fairly unusual place to put a central venous line. Well, let's resume with going downwards a little bit more. Now we have a very irregular shadow here because we're looking at a portion of the left pulmonary artery and a portion of the main pulmonary artery. You can see that the trachea has reached the bifurcation and has started to spread out. You can see behind the trachea the azygous vein, which in this diagram is still on its way back to its position in front of the spine, and you can see the esophagus back here, ascending and descending aorta. You'll often see a vascular structure over here, and we'll be taking a better look at what that is in a moment. On the right side also, we'll see the superior vena cava, and again we may see a vascular structure crammed in next to it on some CT scans over here. Here is a scan of a comparable region in our prototypical patient. This is the main pulmonary artery, and we still have left pulmonary artery here. The air shadow of the main stem bronchi are not seen terribly well with mediastinal windows because we can't see the walls to see their continuity. And the esophageal air bubble merges with the air shadow of the bronchus. Obviously, you can't do very good anatomic dissection using this window alone. The azygous vein, in this case, is pulled over to the left side because the esophagus is pulled so far over because the aorta is so tortuous. Notice a little vein running in the fat over here, probably another tributary of our friendly superior intercostal vein. If we go down a little bit further, the left pulmonary artery becomes interrupted because we are now at the level of the left bronchus, which it must go over. Therefore, there is no more left pulmonary artery by the time we get down to the level of the bronchus. we now are at the level of the right pulmonary artery, which is a lower structure than the one on the left. The descending portion of the left pulmonary artery may be seen over here, posterior to the bronchial shadow. Let me reinforce this anatomy because it's very important not only for interpreting CT scans, but also for reading chest films. Here is an old venogram, actually done in the supine position, superior vena cava. Notice the relationship of the superior vena cava to the right pulmonary artery. It indents the back of superior vena cava. You will see that fairly routinely on CT scans if you look for it. The outflow tract of the main pulmonary artery is quite continuous with the left pulmonary artery. Hooks right on back without any clear demarcation. The right pulmonary artery, on the other hand, comes off almost at right angles to the left pulmonary artery to cross the mediastinum in front of the airway. And here we see the bronchus being crossed by the right pulmonary artery in front of it. The left pulmonary artery then continues posteriorly to go over the left bronchus before heading inferiorly to become the descending limb. Meanwhile, of course, this left pulmonary artery has given off some branches to the upper lobes, which we will not have to study any further here. If we now look at the CT scan, down at the level of the main portion of the right pulmonary artery, you can see we're completely out of the left pulmonary artery, but there is a vascular structure in front of the bronchus. Now, that's not a bulge of the left pulmonary artery. That's something else entirely, and as we will see in a moment, that is a pulmonary vein from the left upper lobe. There's another little shadow over here that you will see on some, but not all, CT scans at this level, and that is, in fact, the tip of the left atrial appendage. Meanwhile, behind the left bronchus is the left pulmonary artery, usually separated from the descending aorta by a little bit of lung in a normal chest. Here's a CT scan at a very comparable level. A dense, contrast-filled shadow in front of the bronchus is the left upper lobe pulmonary vein, a little bit of the left atrial appendage here, the right pulmonary artery crossing the mediastinum, the ascending aorta. Look at the superior vena cava. It's all squashed in here. It's a very compressible structure, isn't it? If we look behind the bronchial line, we see the descending pulmonary artery on the left, a little bit of aerated lung, and then we see the aorta. Two more shadows. Well, we've got two things to account for. We've got the esophagus, and we've got the azygous vein to account for. A little density here between the bronchi, as we will see. That is a frequent variant, a little perhaps of a calcified node, or perhaps just a little bit of cartilage at the bottom of the carina, giving a small dense shadow, otherwise surrounded by fat. Let's look at an anatomy diagram of this region. The structure that runs in front of the left bronchus, as you can see, is the left upper pulmonary vein. It curves around at a fairly steep angle behind and underneath the left pulmonary artery, which curves over the bronchus. Notice the orthogonal relationship of the right pulmonary artery, and notice that on the right side, the vein is in a different relationship. It's not in front of the bronchus, it's in front of the right pulmonary artery. Now, the artist has portrayed it here as if the pulmonary vein is indenting the pulmonary artery. In fact, it's more often the other way around, since the artery is a stiffer structure, and this vein may be thrust into prominence of varying degrees depending upon the tortuosity or the dilatation of the right pulmonary artery. That's a very important finding on plain films of the chest. This is not an important finding on plain films, but this is a conspicuous finding on CT scans. Once again, a slightly different level, very slightly. Once again, a slightly different level, very slightly further down, we see the dense shadow of the left upper pulmonary vein, a little bit of the left atrial appendage, and a little bit left over of the right pulmonary artery. So one must not confuse this on a non-contrast scan with a peribronchial lymph node. It helps to compare it with the adjacent windows. Here we have transferred directly to the lung window, and we can see the branches of that vessel coming out. That way you can distinguish that from a mediastinal mass. To reinforce this further, if it's necessary, let me show you a venous phase of a left pulmonary arteriogram. The left atrium is down here. The plane of the airway is shown here. Here we see the left bronchus end on. In front of the plane of the airway, we see this vascular structure coming down into the left atrium. That's the left upper pulmonary vein. Notice that the pulmonary veins from the lower lobe come in at quite a different angle into the left atrium. They're coming in from posteriorly and inferiorly. So this is the shadow that we see on a CT scan as we cut our way down toward the left atrium. The frontal view shows how the left upper pulmonary vein is quite buried in the hilar shadow. It's usually quite well obscured by the shadow of the pulmonary artery and is rarely perceived on the plain chest film on the left side. The right side, on the other hand, as I mentioned, the pulmonary vein may become displaced and distended by a combination of pulmonary venous hypertension and enlargement of the right pulmonary artery, which also will occur when there is significant heart failure. So you see here, for example, that the vein from the upper lobes is bigger than the vein from the lower and middle lobes, and therefore has quite an abnormal contour, which is visible on the plain film of the chest. If you look at this on the lateral view, here in the arterial phase, you see the artery, but you see that the vein coming down from the upper lobe takes a detour around the prominent arterial shadow and therefore becomes quite conspicuous on the lateral chest film. This, however, does not become so conspicuous on the CT scan, and you have to work quite hard, I think, to pick up this little shadow over here, lateral to the somewhat compressed superior vena cava, represents at least a portion of the right upper pulmonary vein in this patient. One of the problems in routine chest radiology is a patient like this one who is in heart failure. The hyla are often engorged by large arteries and large veins, and we sometimes have a great deal of difficulty distinguishing vascular structures from non-vascular structures in the mediastinum. Well, it's a little easier on CT scan, but it isn't always a cinch. Let's follow this patient's film on CT scans.